Good afternoon, and welcome to this teleconference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Payne. I'm your host, Chris Payne, editor for MS Focus. I'm delighted to introduce our speaker today, Dr. Ben Thrower, who will be presenting Are You Tired of Being Tired? MS Fatigue. Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for MS Focus Multiple Sclerosis Foundation, and he enjoys contributing to our quarterly MS Focus magazine. We're pleased to have him here to join us this afternoon. Dr. Thrower, thank you for being with us, and I'll turn it over to you.
Great. Thank you, Chris, and thank you to all of the other folks at MS Focus behind the scenes who work so hard to make programs like this and other ones possible. We really appreciate all that you do. So we're going to spend a little time talking about fatigue in multiple sclerosis. We'll try to leave some time at the end for questions, and hopefully I'll have some answers to those questions as well. So fatigue is one of the most common symptoms that we see in multiple sclerosis. It's also one of the most bothersome symptoms for many people. Many people with MS would list fatigue as their #1 symptom complaint. Interestingly, it's also one of the leading causes of vocational disability. And so in spite of all of those important things about fatigue and MS, fatigue almost doesn't do the symptom justice, because we all get tired from time to time. You could say any of us could be fatigued. But when we say fatigue in MS, we really mean fatigue that limits your activities of daily living. It makes you non-functional. So we're going to take a little deeper dive into fatigue and look at different causes, different types, and maybe some treatment options for that. I sometimes think of fatigue in MS as almost like a nasty, octopus, eight tentacles reaching out to you, and in each of those tentacles representing a different sort of type of fatigue or cause of fatigue in MS. So we're going to talk about two of the primary causes of fatigue in MS. So this is fatigue that is a direct result of MS. So lassitude and nerve fiber fatigue, those top two tentacles. We're going to talk about other things that might not be directly related to your MS, but that can certainly contribute to your fatigue: underlying sleep disruption, mood disorders, medications, deconditioning, something called compensation, and I'll talk a little bit more about what we mean by that, and then other medical conditions. So realize that, with these 8 tentacles of this fatigue monster, just because you have one doesn't mean you can't have others. So you may be touched by different arms of fatigue all at one time, and it may vary from time to time as to which one is more important and which one's really driving your fatigue with your MS. So when we think about primary MS fatigue, there are really 2 different types. There is lassitude and nerve fiber fatigue. So lassitude is an overwhelming sense of tiredness that is not directly related to heat or exertion. It just is. Comes on out of the blue. Many people will describe this as like a lead blanket over your body. I just can't physically get up. I'm just too tired. Or trying to swim with a fur coat on, just this overwhelming sense of heaviness that comes on. Nerve fiber fatigue is tiredness or dysfunction that's more directly related to heat exposure, exertion, or both. So when we think about lassitude, again, it's this non-exertional, non-heat related fatigue. It is not necessarily correlated with what's going on your MRI or with your level of disability. So you can see folks that would, by most objective measures, by MRI or by a measure of disability by EDSS, might not be considered to have severe MS, but they're dealing with very severe lassitude that can actually significantly affect their activities of daily living. We think that that lassitude in MS may correlate with some of the inflammatory markers we see in MS or cytokines. Again, it doesn't really correlate especially well with MRI findings. Realize as we go through these different types of fatigue in MS that one of the challenges is because there's not good correlation with some of the more objective things like MRI findings or disability. It's sometimes there can be friction created between people dealing with MS, dealing with fatigue, and family members, co-workers, supervisors at work, because this fatigue that people deal with that's so limiting, it's not something that someone can look at you and say, oh, you must be having a horrible day. If you have walking issues, if you're, say, using an assistive device for walking, people can see that and it's obvious. If you're having a bad day with fatigue, it's not always that obvious. The National MS Society for years has had a great little brochure out called But You Look So Good. And it sort of speaks to some of these invisible symptoms like fatigue and cognitive dysfunction and pain that can really affect people's quality of life. So these are some of the things that we can do to help manage lassitude, this type of primary MS fatigue. So it sounds counterintuitive, but we want people to stay active and exercise. It's kind of a catch-22. You may feel like you're too tired to exercise, but we can almost guarantee that if you don't keep moving, you will decondition, and it will likely make your fatigue more obvious. Energy conservation. So this is the concept of not sort of having these highs and lows. Many people with MS will have a good day from an energy standpoint, and they'll try to cram 2 days worth of activity into that one day. And then what they do is they crash for 3 days after that. So they go through this, roller coaster cycle of good days, bad days. And what we'd like to do with energy conservation is try to spread that workload out over time so that you're not potentially going through this roller coaster of energy. Depending upon what sort of MS setting you're in and what sort of comprehensive center you're working with. So in some places, occupational therapists may work with energy conservation. In other places, it may actually go under speech language pathology. The speech language pathologists wear a lot of different hats in the MS world. So it may be something you want to look into. Medication-wise, we have a very old medication, amantadine or Simitril. This is an old anti-influenza drug. Decades ago, there was some thought that MS might be linked to influenza. It was not, but in some of the early studies, when they were trying to manage MS with amantadine, this anti-influenza drug, whereas they didn't change the course of MS, what they did find in about 40% of people with MS is they got a nice energy boost with it. So amantadine is a maintenance medication. It has to be taken twice a day, every day, to see some effect from it. And again, there's about a 40% chance that a person might get an energy boost with that medication. Provigil and Nuvigil, the generics on those are modafinil and armodafinil. These are medications that the FDA categorizes as wake promoting agents. They were originally designed for narcolepsy. They can be useful in multiple sclerosis. Realize as we go through these different prescription medicines that none of these are FDA approved for fatigue and multiple sclerosis. There is no FDA approved medication for fatigue and MS, in spite of it being the #1 symptom complaint for people with MS. Why is that important to think about? If your insurance carrier is looking at covering one of these prescription drugs for fatigue, if you use an off-label drug and it's inexpensive, chances are your insurance company doesn't care. They're going to pay for it. If you use an off-label drug and it's expensive, your insurance company may care. So with Provigil and Nuvigil, these are relatively expensive drugs. What I tell individuals when I'm prescribing these is I'm going to print you a prescription, have you take it to your pharmacy. If your pharmacy says that there's a prior authorization required, chances are your insurance company is not going to pay for it. And at that point, we would have you use the Good RX app or something similar on your phone. These apps can save you a ton of money on drugs like Nuvigil or Provigil, and unfortunately, then the person is going to pay out of pocket, but there's a significant cost savings with one of these apps. The other prescription medicines that we sometimes look at are the true stimulant drugs, and there are many, many of these out there. So on the slide here, I just put Ritalin and Adderall. That would be methylphenidate and dextroamphetamine. These are just the most common examples of these medications. There are, again, lots of other ones. Some of the differentiation between a drug like methylphenidate and some of the other drugs might be that methylphenidate is a relatively short-acting drug, where some of the newer ones are longer-acting drugs. Again, when we get into these medications, realize they are off-label for fatigue and MS. Generally, Ritalin and Adderall, or the generics of these, are relatively inexpensive. Insurance companies will generally pick them up. When you get into the more expensive, longer-acting forms, that's where we may meet some resistance from your insurance carrier. And then, interestingly, there are some over-the-counter, what I would consider to be sort of alternative therapies. L-carnitine is a supplement that you can find easily. There have been numerous studies that have looked at potential energy benefits with L-carnitine in people with multiple sclerosis. The dose on that would be 1,000 milligrams a day. You're going to take one in the morning, and you try it for about a month to see if it gives you an energy boost or not. Generally, very safe and fairly inexpensive. There was a more recent study or earlier this year that looked at oral lavender capsules. Normally we think of lavender as something that you would take at bedtime to have a calming effect or help with sleep. And in this study, which was a double-blind placebo-controlled trial, small, 24 individuals in each arm, so one group on treatment, one group on placebo, they did see a rather dramatic increase in energy levels in the group taking oral lavender capsules. So lavender capsules, literally just the ground up flower put into a gel cap. You can find these in natural food stores. You can order it on Amazon. The dose that they used was 600 milligrams once a day, and safe and inexpensive. So there was a study that came out just last month that looked at another potential way of managing fatigue. This was with something called CBT, or cognitive behavioral therapy. So cognitive behavioral therapy is a sort of a psychological approach to sort of looking at how you think about things and how you kind of process information, and how that can affect both your mood and your level of physical functioning. So this is usually a process. It might vary from 6 weeks up to 12 weeks of working with a psychologist. And in the study that came out in August this year, they found that people with MS dealing with fatigue who did this course of CBT did have a significant improvement in their energy levels. So this is just one more tool that you might think about for managing your fatigue. So we get a lot of questions from the MS community on various diets and how diet might affect multiple sclerosis. This was a study from 2019, fairly large, 281 people, looking at people pursuing a diet that was higher in fruits and vegetables, lower in saturated fats, really something that looked kind of like a Mediterranean diet. And what they found is that people did report better energy levels. And when they did sort of markers of inflammation with blood testing, these inflammatory cytokines, interestingly, they found that there was a significant lowering of inflammatory cytokines on blood testing. So the other type of primary MS fatigue that we talk about is nerve fiber fatigue. So here on this slide, you can see on the top here, this is a myelinated nerve fiber. This is the way things should work in the central nervous system. So here, buried this in the myelin, is this yellow axon or nerve fiber. You have these little gaps in the green myelin called nodes of Ranvier, and normally sort of the electrical information sort of jumps from gap to gap in a very fast, very efficient way called saltatory conduction. Now MS comes along and it's going to kind of throw a wrench into things. You're going to strip the myelin away, so you have this naked nerve fiber. That electrical information can no longer jump that gap, so it has to reconduct itself in little baby steps across that naked nerve fiber. It is a backup plan. It does work, but it's not as fast and it's not as efficient as the original sort of way of working. So what happens with this sort of naked nerve fiber is it is prone to something called conduction block. So what conduction block means is I've sort of raised my core body temperature, or I've done an exercise that uses this naked nerve fiber over and over again in a way that I've drained the battery. So I get an electrical block there. What's really important to know with conduction block in multiple sclerosis or nerve fiber fatigue is that you're not hurting anything. Some people get frightened if they exercise or do an activity and they have a symptom act up. They get worsened foot drop, for instance. Realize that if this comes on with exercise or heat exposure, that it's purely an electrical phenomenon. You're not causing new damage in the central nervous system. When you rest, cool off, your battery will recharge and you'll be able to sort of function again. So it's annoying. It is challenging sometimes to design strategies to work around this. The official term for that from a medical standpoint is Uthoff's sign. So Uthoff's sign was originally designed to describe worsening of vision with heat exposure. So Dr. Uthoff was actually a neuro-ophthalmologist in the late 1800s who, this was pre-MRI, pre-spinal fluid evaluation. So one of their ways of potentially diagnosing MS was to put the person with MS in a tub of warm water and see if the vision in one or both eyes got dimmer or went out completely. And that was one of the ways they diagnosed MS at that time. We've sort of expanded that definition of Uthoff's now to describe really any sort of symptom that worsens with heat exposure, whether it's vision dimming, feet getting number, legs dragging, almost anything that worsens with heat. So what do we do for nerve fiber fatigue? Well, if heat is an issue, we're going to look at cooling strategies, anything we can do to keep your core body temperature cooler. There's an old oral medication, 4-aminopyridine or 4-AP. This is a non-FDA approved, mom and pop compounded, medication. So this was made by compounding pharmacists. It's been around for many, many decades. A sort of FDA approved version of that would be Ampera, which is now has gone generic in the form of dalfampridine. This was FDA approved to improve walking speed in people with MS. So why walking speed and not other symptoms? So when we think about 4-aminopyridine, we never thought of that as a walking drug. We thought of it as a medication that could potentially improve any symptom of MS that worsened with heat or exertion. That's a pretty broad area to talk about. So when a drug company wanted to get FDA approval and design a study for their version, the dalfampridine, they had to really narrow it down. They had to pick something very specific. So they just happened to go after walking speed. Could dalfampridine help with other things? Yes, we believe so. It's just that the FDA approval is officially for walking. With both of these, the 4-aminopyridine and the dalfampridine, the chances that you would see a benefit in terms of better walking, better heat tolerance is about 40%. We don't understand that. We don't know why 60% of people with MS get no benefit at all. But we've seen that with both 4-aminopyridine and dalfampridine. And generally what we want people to do is give one of these about a 4-week trial and kind of get a sense of which group you're in, the responder or non-responder group. So these are cooling garments, big proponents. We've just had a really crazy hot summer here in Georgia, as much of the country has. And so we've been referring a lot of people out for different cooling garments. There are vests, hats, neck wraps that all work, either by evaporation, ice packs, gel packs, to help keep your core temperature lower. I will say the technology with cooling garments has advanced quite a bit over the years. Our old vests were, really, they had the ice packs in them. They worked, but they were bulky. They restricted movement. They were kind of heavy. Some of the newer cooling vests, much more functional, much lighter weight, potentially could be worn under other layers of clothing and not even be obvious. I'll brag on the MS Focus folks. There is a great cooling program. If you are in need of any kind of cooling garment, do take a look, go on their website and look under the cooling vest scholarship program. I feel I've probably inundated the folks at the MS Focus this summer. I felt like I referred a ton of people over because of how hot it was here. I put this up there. You know, sometimes people get tricky and sort of improvise their own cooling strategies. Camelbacks, if you're not familiar with these are sort of like a canteen, soft canteen in a backpack form. So that the backpack that the gentleman has on here, they come in different sizes. You can do a 1 gallon, a 2 gallon, and then there's this little straw that comes around that sort of attaches to a clip on the front. So why do people look at these with MS? Well, if you put a sort of a slushy, slurpy ice water consistency liquid in here, so put ice in a blender, put water in it, you know, fill this thing up, you've kind of got an improvised cooling vest right over your core. Plus, you've got a super chilled liquid that you can sort of, you know, drink on a hot day. What we know is that if you drink something that has that slurpy, slushy consistency, it probably drops your core temperature a little faster than just drinking a regular cold liquid. So this could serve as 2-in-1 for you. And they're relatively inexpensive. Get them on sporting goods stores or on Amazon, REI, places like that. So I put mood disorders up here because it sometimes can mimic some of the things that we see with fatigue and MS. So depression is common in multiple sclerosis. One of the potential symptoms we see with depression is anhedonia, a lack of hedonism or a lack of desire to do things you would normally find pleasurable. So an example would be, you know, maybe there's a restaurant that you like going out to. Your significant other says, you know, it's Friday night, you normally go out to this great restaurant and you just don't feel like going. It's just not appealing to you. You're hungry, but it's just doesn't feel like it's going to be much fun. So that lack of desire to do something you normally find pleasurable is a potential symptom of depression. It can sometimes mimic the fatigue we see with multiple sclerosis. So one of the questions to ask yourself if you're not sure if you're dealing with this is, if there's something you would normally like to do and you don't feel like doing it, is it because you're too tired to do it, or is it because you really don't have the desire to do it? Those may be different things. And realize a person with MS can deal with both. You know, sometimes it may be one and sometimes it may be the other. So it's helpful to your healthcare team if we can help tease out maybe that symptom of depression. That treatment pathway for depression could be different than just regular fatigue management. With depression, we might look at counseling, stress management, exercise. Interestingly, it does help with mood in many people. And then there are certainly a wide range of medications that we can use to help manage depression. Sleep disorders in MS, this is one of those arms of that eight-legged octopus. Sleep disorders are very common in multiple sclerosis. They've been estimated to be present in perhaps 70% of people with MS. And these can be primary sleep disorders, things like obstructive sleep apnea. And so one of the clinical clues that we might use to help determine if your sleep is adequate is, how do you feel when you first get up in the morning? Are you reasonably well rested, even if for only a short period of time, even if it's only an hour? If you're reasonably well rested, and when you first get up in the morning, it makes us feel better that maybe there's not an underlying sleep disorder. If you're tired from the minute your head gets off the pillow, then there could be an underlying sleep disorder. You know, we sometimes look at significant others for help in picking up symptoms of sleep apnea. People with sleep apnea are usually pretty noisy snorers, and a lot of times the family members, significant others, are going to say, yeah, they definitely have things that would be consistent with sleep apnea. Realize there are symptoms with multiple sclerosis that can be disruptive to sleep. Spasms occur commonly at night. Neuropathic pain or burning in the extremities may be more common at night. Urinary symptoms, if you have to get up every hour to go to the restroom, that's obviously not going to be very conducive to a good night's sleep. So we want to tease those things out, and by managing those MS symptoms, we may improve sleep and thereby improve your daytime energy levels. The good news with various symptoms with MS is that almost any symptom that you can think of with MS, we probably have a medication we can use to treat it. The bad news is that almost any symptom you think of with MS, we probably have a medication to treat it. So we have, and the reason that's both good and bad news is that if we're not careful, we can sort of dip into what we call polypharmacy, or prescribing too many medications. I was taught in medical school that if a person's on two drugs, we can probably predict what the drug-drug interactions are going to be with two medications. When you get into 3, 4, 5, 6 more medications, those drug-drug interactions get very difficult to predict. Any of our medications, I would say many of our medications, does have the potential to be associated with fatigue. So when we think about some of our antidepressants, some of our old things like amitriptyline, nortriptyline that we might use for pain or sleep, can sometimes then give you daytime fatigue because they have a fairly long half-life in your system. A lot of our anticonvulsant medications that we might use for pain management, for instance, or headache management, topiramate, gabapentin, these things can be sedating as well. Antispasticity agents, sadly, we don't have an antispasticity agent that is not associated with some potential for fatigue. Analgesic medications, some of our bladder medicines, our older platform therapies like beta interferons can be associated with fatigue. So we have to sort of be mindful of all of those things when we're looking at your energy levels. The other thing that can lead to fatigue is deconditioning. And so when we think of deconditioning, I think of it as part of a bucket of disability. And I borrowed this from our physical therapy folks. So when we look at disability in a person with multiple sclerosis, a lot of times we think of that sort of disability as being a bucket, and there are two ingredients in that bucket. There's damage in the central nervous system. So demyelination, axonal or nerve fiber damage can certainly lead to a disability. Deconditioning can lead to disability. And the reason we want to think about deconditioning is that, while research is working towards fixing number one, the damage in the CNS from multiple sclerosis, we don't have an FDA approved neural repair agent, but we do have things we can do for deconditioning. And we know if we work on deconditioning that we make your bucket smaller. And so we work a lot with wellness programs, exercise physiologists, physical therapists, occupational therapists to try to get you in the best shape that you can be, because we do know that this will pay benefits, not only in terms of energy levels, but just walking ability, activities of daily living. And realize that there has been an evolution in the way we think about exercise in multiple sclerosis. It feels odd as we sit here today to realize that going back to the 1970s and earlier, we told people with MS that exercise was bad for them. That evolved then into, okay, maybe it's not bad for you. It's okay. You can try it out, to knowing now that really exercise is vitally important and good for people with multiple sclerosis. One of the questions that we get commonly is, what is the best form of exercise for a person with MS? And the simple answer is, it's whatever you enjoy, you'll stick with, and you have access to. There are many forms of exercise that are beneficial for people with MS. The underlying principle is that we would like some balance of some stretching exercise, some aerobic exercise for cardiovascular benefit, and some resistance training. And how you accomplish that is going to be unique to what you enjoy, what you have access to, and what you're willing to stick with over time. So one of those arms of that octopus was compensation. What do we mean by compensation? We mean that if MS has thrown a challenge at you, let's say a walking issue or a balance issue, the way that you try to compensate for that can lead to you using more energy. A classic example would be foot drop. So when you look at someone whose foot wants to drag, if your hip flexors were strong, you would bring your foot up higher so that you don't drag your foot. Most people who have foot drop also have weakness in their hip flexors, so they can't do that. So what they end up doing is they do this very abnormal gait pattern called circumduction, where you swing your leg out and around. It's a very abnormal way to walk. You're using muscles to walk that you weren't designed to use. You're putting extra stress on your knee and your hip and your lower back, and you're using a lot of extra energy. There was a study in April of 2019 that looked at people with progressive forms of MS, and they found on average that just to carry out daily tasks, just everyday activities, the person with progressive MS was using 2.8 times more energy than a person without multiple sclerosis. And this is, it exhausts people. You know, a lot of our folks with MS will say, I start the day here with my level of functioning. As the day goes on, I'm just withdrawing, you know, more and more energy from my savings account, and I become less and less functional as the day goes on. Some of that is because of these compensatory mechanisms that people have to use to get around what MS is thrown at them. So when we think about decreasing the need for compensation, this is where we're going to rely heavily on our physical therapists, occupational therapists. We might take a look at some medications. So we would love to be able to improve your level of functioning through therapy, but if we can't improve it, we'd like to help you adapt to it. And this is where assistive devices, braces, canes, walkers, different things may help you work more efficiently and not rely on these compensatory mechanisms that are going to suck your energy away. Some of when we think about foot drop, there are these various functional electrical devices that we have. There's Walk Aid, the Ness L300 from Bioness, and then the most recent addition to the lineup has been the Neural Sleeve. These are other just sort of more high-tech ways that we might be able to improve your foot drop and have you walk in a sort of a less exhausting fashion. Reconditioning, again, we talked about how that's an important thing to kind of decrease your disability bucket. And then the medications that help with nerve fiber fatigue, things like forminopyridine and dalfampridine, might be things that decrease the need for compensation. And then finally, just because you have MS doesn't mean you can't have other health conditions. And there are other health conditions that can be associated with fatigue. So again, MS doesn't protect you from other health conditions. So if you're dealing with fatigue, we want to keep in mind that it could be partly driven by thyroid disorders, diabetes, vitamin deficiencies. So we're pretty liberal with drawing blood tests for these other metabolic conditions if you're dealing with fatigue, just to make sure that we're not missing something that could be easily fixable and have other health issues for you down the line. So with that, we're going to turn it over back to Chris and the audience to see what questions, thoughts, challenges people might have as it relates to fatigue and MS.
Now we're ready for some questions. I want to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you choose, or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you'll be able to unmute and ask your question. And we already have our first question from Linda. She asked, do you consider a bout of fatigue a relapse?
No. So the strict definition of a relapse is it's a new neurological symptom that comes on and lasts for at least 24 hours, or it's a worsening of an old neurological symptom that comes on and lasts for at least 24 hours. And then we put a little asterisk behind that and said, but we don't include certain things like fatigue. Worsening of pain is not necessarily a true relapse. So if it's fatigue all by itself, realize that fatigue in MS is notorious for waxing and waning. People clearly have good days and bad days. And sometimes you may be able to think about, what did I do? I had poor sleep, I'm stressed, I have a viral infection, that's what's worsening my energy levels. Sometimes there's nothing that you can point to. It just is. And that is the nature of fatigue in MS, that it does wax and wane. And that by itself, we would not consider to be a true relapse.
All righty. Our next question will be from Dee. Dee, can you hear us?
Yes. Can you hear me?
Yes, we can. Go ahead.
Okay. Hi. So I was diagnosed with multiple sclerosis. I'm a resident physician. and it's really tiring having MS and going through residency. Do you have any tips for people that work like over 80 hours a week? I mean, I'm trying my best to sleep,
Yeah.
exercise, and eat well, but is there anything else you can give recommendations for physicians like us, residents?
So first off, congratulations for getting through medical school and best of luck through residency. We have a number of physicians, including all the way from medical students, residents, all to physicians who've been practicing for years that we work with. I would, if your residency director is not aware of your MS, I would certainly, if you're comfortable, make them aware of it and see if there are any accommodations that could be made in regards to call and number of hours worked. Make sure you're taking care of yourself, that when you can get sleep, trying to keep your diet as healthy as you can. I know it's hard to find a regular exercise program when you're working 80 hours a week, but do try to carve out something for yourself. And then if you need medications, I think for someone in your position, where there's a lot being asked of you, things like modafinil or armodafinil, because those can be used on an as needed basis and you don't have to take them every day, you might find a way to kind of work that into your regimen to see if it can help you get through things. So hopefully between all of those things, you'll find a way to get through. I will say, in some of our folks that have gone through residency programs, we have had people, if need be, even take little sabbaticals. It might extend the length of your residency a little bit, but you do
Yeah,
what you have to do to take care of yourself, through this.
absolutely. Thank you so much.
Absolutely. Good luck to you.
Thank you.
And thank you, Dee. Best of luck to you. Our next question comes from Anonymous. My doc prescribed Adderall to help with fatigue. I have not tried it yet because of the potential side effects. What are the most common side effects and what are the chances they will actually happen? Thank you.
So in general, most of our folks who are using Adderall or dextroamphetamines, the generic, or methylphenidate, which is the generic for Ritalin, have been pretty happy with them. So occasionally, I would say the most common side effect we see is sometimes they work a little too well. So someone takes a dose and they feel, like they've had a cup of coffee too much, in which case maybe we just lower the dose or we pick a different option. There is the rare individual who just doesn't respond at all. They just don't get any benefit whatsoever. You sometimes have to play around with your timing of the dosing. You don't want to take these medications so late in the day that they potentially interfere with your sleep at night. And sometimes that takes a little bit of trial and error to find out what's going to work for you. Once in a while, you'll see people have headaches with stimulant drugs like that. You can see decreased appetite, and we have seen weight loss. Sometimes people appreciate it. Sometimes it's more than what they want. So those are some of the more common things we deal with. There is the potential for addiction and or tolerance to these medications. I've just not seen it in the 30 plus years I've been doing this. We make people aware of it. These are controlled substances. There is the potential for street use. So, if you're on one of these drugs, do kind of keep a watch on it. If you have, strangers coming into your house or something, do realize that there is some street value to these medications, and it's not crazy that someone might steal it from you. So yeah, those are the more common things we see with the stimulant drugs.
I want to take this opportunity to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you will be able to unmute and ask your question. Our next question comes from Miriam. I wake up, I feel fine as day goes on, I become dizzy. Is this a form of fatigue?
So dizzy means different things to different people. So some people, when they say dizzy, they mean that they're lightheaded. maybe they're going from lying to sitting, sitting to standing, and they feel like they're going to pass out. So that's one form of dizziness. In other people, they're actually describing more of a vertigo, which would be kind of that sense I'm moving or spinning when I'm really not. And then other people, when they say dizzy in MS, what they may actually be describing is that their balance is off. And that may be due to decreased position sense or proprioception in their legs. And so they're off. They feel like they're walking and they've had a drink too many. You may be dealing with a little of any of those. And so I would say typically with lightheadedness or vertigo, that's usually not a form of true fatigue in MS. You could argue that, if you have nerve fiber fatigue, so you're using those demyelinated nerve fibers more and more as the day goes on, and maybe it manifests as decreased sensation in your feet, that maybe poor balance could be a form of nerve fiber fatigue. But I would certainly talk to your healthcare team so they can help tease out, which of these or which combination of these is driving your symptoms and come up with a treatment plan for you.
All right. Our next question comes from, and I hope I'm going to pronounce this right, Keeler. Is strength training the only way to recondition?
So strength training, again, is one of those forms of exercise. So resistance training is something we do like to see, as a part of your exercise program. But again, you want to kind of balance that out with some stretching and some, a little bit of cardiovascular as well. Sometimes you can, if you're not sure what you should be doing, you can work with an exercise physiologist at a wellness program, or a lot of health clubs have a trainer that might help you design, an exercise program that's going to be a good fit for you. So yeah, the strength training is just part of that big picture of a well-rounded exercise program.
Our next question comes from Anonymous. Is napping recommended for managing fatigue?
It's a tool in the toolbox. There's nothing wrong with napping. Whether that's something that you can use to kind of help recharge your batteries really probably depends upon your individual situation. So, some people that are maybe working, our D or, or former, our resident in training, probably doesn't have a chance to take a lot of naps. Someone else, maybe if, that's retired or doesn't, have a regular work schedule, maybe they are able to use a nap to help recharge their batteries. So there's nothing wrong with napping. It's really a question of, is it an option for you?
I want to take an opportunity here to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you'll be able to unmute and ask your question. Speaking of the next question, it comes from Arletha. Arletha asks, has B1 supplement been used to help with fatigue?
So I would say any of the B vitamins have been looked at for energy levels. Probably B12 is the more commonly thought of B vitamin for energy levels. Statistically, there is a little higher incidence of vitamin B deficiency in the MS population. So we do check vitamin B12 levels pretty regularly. So if you have a B12 deficiency, we can certainly try an oral B12 first to start off with. If the vitamin B12 levels don't budge with oral doses, we may need to go to an injectable form. Some people don't absorb B12 especially well in an oral form, so that may be why we need to go to an injectable form. There is another form of B12 out there called Nascobal. It's an intranasal form of B12. It's an alternative to injections. I wish we could use it more regularly. It's rather expensive, and the insurance coverage has not always been great for that. So yeah, I would say we certainly think about B vitamins as it relates to fatigue, but probably B12 would be the most common one we look at.
All right, our next question comes from Andrew. Andrew, can you hear us?
Yeah, I can hear you.
Feel free to ask your question.
Yeah, talking about exercise and fatigue. I do physical therapy every day, and I start off with kind of a little bit of riding exercise, bike and stretching. And then usually I'm unable to progress into some like physical therapy strength conditioning because I start to feel lightheaded and to feel a little bit more fatigued. And so I'm wondering if that's a sign of like a relapse, or if this is a normal thing that people deal with, and if so, if there's anything that you suggest for that.
So I think what you're describing is nerve fiber fatigue. So it's not a relapse. It's more that with exertion, and when you're doing your exercise, you're probably raising your core body temperature a little bit. So you're draining that battery electrically. So again, these are the areas of old demyelination. And again, nothing dangerous about it, but obviously it's physically limiting to you. It's changing kind of what you're able to do with your exercise program. You can try mixing, maybe you don't do all three things the same day. Maybe you don't stretch, strength train, and do something, your cardiovascular on the same day. Maybe you kind of spread them out a little bit. One of the things so there's a group out called Can Do MS. They do a lot of work with exercise in MS. And before they were Can Do, they were called the Jimmy Hugo Center. And what the Jimmy Hugo folks really try to emphasize is teaching people to exercise to an internal target rather than an external target. So a lot of times when we exercise, we're very fixated on, I've got to do 30 reps of X, or I've got to do 20 minutes. It's these very hardwired objective targets. That doesn't always work with MS. And so realize that you have good days and bad days. And so what we're trying to get people to do is listen to their body. The technical term is the perceived exertion rating scale. It's this learning to listen to what my body's telling me. So if let's say you're doing a treadmill, and after so many minutes, your foot starts getting numb, or maybe your foot's dragging a little bit. For that day, that's probably you've hit the wall for that day. So you're done for that day. Maybe it happens at 5 minutes one day. Maybe it happens at 30 minutes another day. That's okay. Giving yourself the grace of flexibility and learning to listen to your body is really, I think, critical for many people with MS. The other thing that I've learned over the years is that we are creatures of habit. And so when you get into an exercise program, you want to try to stick with it. You've built that schedule, you built that routine. Let's say you get up one day and you just don't feel like doing it. Go through the motions at least. If you're using exercise equipment in your basement, go down and at least say hello to it. You may not use it that day. You maybe just stand on it, touch it. It's okay. You've at least kept to that schedule. If you're going to a facility to exercise, drive to the facility, sit in the parking lot if you have to, but at least you're keeping that routine. And so what we see in humans, MS or not, is if we break our routine, it gets that much easier to break the routine the next day and the next day and the next day. So again, just I think one of the take-home messages is be flexible and learn to listen to your body and use those internal cues more than you use the external targets.
Thank you.
Yeah, thank you.
And thank you, Andrew. Our next question. I will randomly get super fatigued while driving and can almost not keep my eyes open. It worries me for many reasons. Can people get their license taken away because of MS and fatigue like this?
So it's a little bit of a gray area. So what that person is describing is kind of classic lassitude. It's this, sudden onset of just overwhelming fatigue. And sometimes people can actually feel like their eyelids are very heavy. They want to nod off. Most states would not have a law that would specifically ban driving in that situation. But at the same time, we want to be realistic. Be realistic with yourself. You don't want to put yourself and others on the road into any situation where someone's going to get hurt. I would make sure your healthcare team knows about that. It may be that it's primary MS lassitude that you're dealing with. We want to make sure that there's not something on the front end, an underlying sleep disorder that's contributing to that daytime fatigue. And so just make sure that we can make you as safe as possible. If you have any clues that you're having a bad day. Maybe you restrict your driving on days like that. But going back to the original question, is there anything about that situation that would, sort of make DMV in a given state come in and take your license? Probably not. But again, do be, just aware of it and be respectful of your fellow drivers on the road, and make sure your healthcare team's aware of that.
All right, our next question comes from Debbie. Would you recommend the BEMER therapy for fatigue?
So I have not personally had a lot of experience with that. We have had patients that have reported that they've seen benefit. I guess I don't have any concern about people trying it. I don't think there's any huge risk to it, but I can't say I've had a ton of experience one way or the other. I have not looked. So when I look up different things for MS in terms of research, we use a site called PubMed, PubMed. I can't say I've looked at that recently, but we can certainly take a look and see if there's anything that's been reported research-wise.
All right, our next question comes from Dakota. Dakota, can you hear me?
Yes.
Go ahead.
My question is would it be okay to add maybe a nutritionist to a person, a healthcare team, to maybe give suggestions for fatigue fighting foods?
Yeah, absolutely. So I think nutritionists, dietitians are always a welcome part of that team. And so we mentioned a study earlier that where people had more of a Mediterranean type diet, and they did see benefits in terms of energy. I didn't put it in this program, but the other diet that we see a lot of interest in is the WALS protocol. The WALS protocol has a dietary component, but it's really bigger than that. There is an exercise component, a stress management component, and what people have seen with research in the WALS protocol, when people followed it for a year, is there a lot of people did report an improvement in their energy levels. So using a nutritionist to help kind of guide you down one of these pathways, I think can certainly be helpful. I think when you think about dietary changes, you want to be sort of realistic also. You want to sort of pursue dietary changes that you can stick with over time. I particularly like the Mediterranean kind of diet, because I think it's something that people don't have to buy anything special. If the whole family's on the Mediterranean diet, that's absolutely fine. It's not crazy restrictive. Thank you.
Thank you so much, and have a pleasant day. Our next question: can increasing water intake help with fatigue?
I would say yes. So clearly, if you're dehydrated, you're going to probably have lower energy levels. And so, yeah, I think staying well hydrated is important. It's probably more than just energy levels, though. So, a lot of people with MS deal with bladder symptoms. So a lot of folks with MS are dealing with urinary urgency and frequency. And sometimes consciously or subconsciously, people will fluid restrict in hopes of managing that urinary frequency and urgency. The thought being, well, man, if I'm going to have to go to the bathroom every 30 minutes, I'm just not going to drink as much, and that'll help with that. The problem with that, then you do end up relatively dehydrated. And ironically and paradoxically, so if you are relatively dehydrated, you actually have concentrated urine. Concentrated urine is a bladder irritant. So you can end up worsening the very thing that you're trying to manage by fluid restricting. The other problem with fluid restricting is it can be relatively constipating, and a lot of our folks are dealing with some degree of constipation, and this just adds to that. So yeah, a lot of reasons you probably don't want to fluid restrict to the point of dehydration.
Our next question comes from Anonymous. What blood tests do I ask my doctor to do to look at vitamin deficiencies?
So the two most common vitamin deficiencies that we would see in MS would be vitamin D deficiency, which is really, really common. And so some studies have suggested that 85% of people with MS are vitamin deficient, and especially in Black women. I mean, we see the lowest of the low vitamin D levels in Black women. And then vitamin B12 deficiency would be the two that I would look at most commonly. There is a little controversy out there about how effective and how aggressive we should be with vitamin D replacement. A lot of studies have shown that by getting vitamin D levels up into a good normal range, that you may reduce your risk of relapses and new lesions on MRI. Other studies have not found that. I will confess I am in the believer camp. I believe vitamin D deficiency should be addressed. So yeah, those would be the two most common vitamins we want to think about.
All right, and our last question for today comes from Kathleen. My doctor recommended alpha lipoic acid.
Maybe alpha lipoic acid.
Yeah, I will take that. I will guess that that's how you pronounce all that. Plus CoQ10 and a probiotic. What are your thoughts?
Absolutely fine with all of those. I would say in terms of published research, there's probably the most is out there for alpha lipoic acid. There have been studies that have suggested that there is a potential protective effect of alpha lipoic acid by mouth. So this is something that can be purchased over the counter. CoQ10 is an antioxidant. So, I have not seen as much published data, but certainly in theory, there's no harm to that. Probiotics are an interesting area. So we know that people with MS, if you look at their gut flora, the bacteria that normally live in our gut, people with untreated MS have a different gut flora than the rest of the population. When we put people with MS on a disease modifying therapy, their gut flora actually starts looking more like the general population. So could a probiotic help sort of promote that normal sort of gut flora? Potentially. If you're ever on antibiotics periodically, I think probiotics are important to those folks just because the antibiotics can change your normal gut flora and the probiotics may help you kind of reestablish that. I think the whole concept of the gut microbiome or what bacteria live in our gut and how that functions in autoimmune conditions like MS, I think we're just scratching the surface right now, but I certainly have no problems with people doing a probiotic.
And with that, we have reached the end of our time for today. If you missed any part of this conference, it has been recorded and will be available through MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings or sign up for our newsletter to learn about upcoming events. Be with us next time when our teleconference will be at 3 p.m. Eastern, when Sherry Binns will host Ask the MS Nurse. Bring your questions regarding symptom management. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Ben Thrower. Thank you so much for the time you spent to prepare and share this information with us.
Thanks, everybody. Have a great day.